Welcome back to Alabama Care, everybody. Today I am with Phillip Crain, and we are going to be talking about um, what people with disabilities want in primary health care and ideas to improve it, and also a little about the STEP program. So, Mr. Crain, if you would introduce yourself.
Hi, I'm Phillip Crain. I work as the STEP Clinic patient navigator. Uh,
Give me 1 second. Sorry. Okay. Um, Also forgot to mention that I will be looking at Facebook comments if we get any questions from Facebook. Okay, so my first question. Everybody gets asked this when they either visit Alabama or they first move there, whatever. Auburn or Alabama?
Auburn. I'm a third generation Auburn alum. I had no other
Yes.
choice. It was
Me neither.
came out of the womb as an Auburn fan, and that has never changed. So
Good.
easiest question you're gonna ask me all day.
Good. I like your answer. Okay, so are you originally from Alabama?
Yeah, I grew up in Birmingham, so I'm originally from
From
that
Birmingham.
same.
Cool. So let's see, let's talk about the STEP program. So, what is the STEP program and how
So
long have you
STEP
been
stands
involved?
for staging transition for every patient, and it's a bridge program between Children's Hospital of Alabama and UAB. And so it's designed to help patients with disabilities and those with complex care needs transition from pediatric care to adult care. So that's the basic premise of it. And so there's kind of two prongs to that. So on the pediatric side, which is Children's of Alabama, there's a lot of behind the scenes stuff that they do as far as getting patients ready to move from pediatrics to adult care. And so
Right.
that's increasing patient autonomy, giving the patient more responsibility with, for their own care within doctor's appointments. That could look like, you know, a patient, them answering the questions from the doctor as opposed to their parent. Uh, and then on the other side is the UAB side, where UAB is obviously the adult home for patients for going from children's to UAB. But with STEP Clinic, what we have is it's kind of a intermediary between the two, to where it's like, okay, you have transitioned from children's and you're done with the pediatric world, but we may not have found you every adult provider that can handle
Mm-hmm.
your disability or complex care needs. And so we have several physicians and social workers and other people on staff with the STEP clinic at UAB that can help meet the medical needs there. And then hopefully, ideally, we find you medical homes within the UAB system, whether it's for OBGYN or, um, you know, whatever disability medical needs that you might have. Hopefully, we find that outside of the STEP clinic at UAB. But until we find that, we will take you as a patient at the STEP clinic at UAB.
Gotcha. Okay. Do you know when it was started? STEP.
So STEP started in September of 2020. And the big, and I need to mention this as well, the big focus with STEP is the difference between the transition process and the transfer of care. And so the transition process is all of the things that get you ready to move from the pediatric world to the adult world. And so that's you're increasing your patient autonomy, doing all of that. That's the transition process. But then the transfer of care is the singular moment where you go from receiving care at children's and the pediatric world to receiving care in the adult world. So,
Gotcha.
um,
Um,
yeah, so STEP
and how
started
long
in.
you got involved?
I got involved in June of this year. So I met Betsy through some other stuff that I had been doing this past spring. And so then Betsy had this position come available through some grant money that she had received. And so then she was like, hey, you're a perfect fit for it. And so that's kind of how we got involved together. And so then it's been good.
Gotcha. That's kind of cool. I love Betsy.
Yes, Betsy's great.
Let's see. Okay, you may have answered this a little bit. Who do you serve for the STEP program?
Yeah, I did answer it a little bit, but I'm happy to elaborate. So STEP is designed to meet the transition needs of patients who are aged 14 to 21 who have either disabilities or complex care needs, and that they're transitioning from pediatrics at children's to adult care at UAB. And like I said, as I mentioned before, our primary care um, providers will meet those needs if necessary for patients who are 18 or older, and then we'll also help with referrals to adult specialists um, and handle some additional, individual transition plans for every patient. The idea behind STEP and that entire transition process and staging it the way that we have is to prevent an interruption in medical care being provided to patients, whether that's physical therapy, social work, emergency needs, all of that. Like I said, the STEP clinic at UAB, in concert with that transition process from children, is designed to meet that, so that there isn't a drop off in that primary care, setting. We know from statistical data that like 1/4 of disabled adults do not have a primary care provider, um, and so that's a problem when it comes to primary care services, and so that creates an issue.
All right. For the audience that is watching, by the way, we're having some technical difficulties. And we have a storm coming in like my area. So if I disappear for a second, that would be why. Okay, so what are the I guess requirements to participate? Or are there any for STEP?
I mean, there are some, but it's not. It's fairly broad. Um, So, like I said, the work that children's does is kind of behind the scenes, and so that
Mm-hmm.
is open to any patient that goes through children's. Um, and then, like I said, we're working with providers to encourage them to discuss that transition process and make sure that patients are better prepared for that transition. Because what we've heard from parents and patients and providers as well is that patients there's kind of been a lack of preparedness, and so patients get
Mm-hmm.
to becoming 18 or 21, and the pediatric provider is going, okay, well, you need to go to adult care, um, and the patient is going, what? I'm not ready to do that.
Right,
they're not ready to leave that familiarity that they have with their primary care provider and their
right.
pediatric specialist. And so then it's like, oh, I didn't think I was going to have to leave. And the specialist or the doctor saying, no, you need to go to adult care. And so there's, we're trying to just boost that, so that when that time comes, there isn't as much of an issue. Uh, and then at UAB, I said when UAB takes over, um, the patient has to be 18. But that's
Mm-hmm.
kind of, but then we'll refer you to specialists. But I said that's, as far as like a requirement, you do have to have that complex need, that complex care need, or that disability. But
Right.
other than that, there's not really a limitation against it. It's just meeting that need.
Right. Yeah. I can kind of one of the patients that was just thrown into adult healthcare side of it
Mm-hmm.
because the STEP program was not available when
Yeah.
I transitioned. So I was also kind of lost. So I get that part.
Hmm. Yeah, I've been there myself. I said there's definitely that fear of like, okay, where am I going, and
Right.
who's going to take care of this disability aspect. I tell this story pretty frequently, so Betsy's heard it a lot. But when I was 9 or 10, my pediatric therapist at the time, she goes, "Be prepared, or start preparing for your transition to the adult world, because the adult world isn't prepared to take care of you with your
Right.
disability and stuff like that." And she was like, and they're not prepared for any of your friends either. And I was like, oh, so 9 or 10, it's kind of on your radar. And like I said, my pediatric therapist was great, phenomenal. Um, and she kind of mentally prepared me, if nothing else, for that, that transition of like, okay, it's gonna fall to you to kind of
Right.
pick up where the medical world is currently lacking,
Right.
and not quite ready for. And so that was kind of my experience with it.
Yeah. I had kind of a similar experience. I didn't, I think I just got used to the same doctors, especially
Mm-hmm.
dealing with like all the like the shunt surgeries and stuff that I have had.
Mm-hmm.
And then having to move to brand new doctors that I've never had surgery with.
Yeah.
Like it's not,
Yeah.
it's scary.
Yeah, I dealt with that. I had a baclofen pump for like 20 plus years. And it was always like, I kept dipping back into the children's well, whenever I had any pump issues where the pump actually had to be surgically managed. And the children's doc kept going, "Why do you keep coming back here?" It's like, there's, I don't know where else to go. And there's that familiarity with children's.
Right.
Okay, they know you, you know them. Like every time I went in the OR, it was, oh, it's Phillip. It's some nurse who had been there for
Yep.
20 years. Knew you, or you went back for follow up stuff, and it was the same, you know, pediatric neurosurgery nurse that's done every surgery, follow up with you for 20 years.
Exactly.
You're
Yeah.
on practically a first name basis.
Mm-hmm.
It's that familiarity is definitely a big draw, to
Yeah.
stay to for and I understand why patients and their families don't want to. They're they're almost afraid to transition, because you do lose that familiarity. And so hopefully what part of STEP does as well, both through children's and UAB, is, if nothing if nothing else, we will always be there, um,
Mm-hmm.
to kind of meet the needs, if that's necessary, or refer you to the people who can meet those needs. We're kind of always in your corner, um, and on your side. So that's one cool thing about that I've seen in the 2 months or so that I've been there, is that there are people like, it's a team of social workers and physicians who, they care about these patients and they want to make sure that their needs get met, and we're not gonna throw you off into the deep end without a life
Mm-hmm.
raft or a life jacket.
Right.
So
Yeah. Okay, so that is actually a pretty good like segue into my next question. What are the reasons why step clinic is so important?
STEP is really important, again, especially on the UAB side. While the children's side is important because we need to boost that transition process and make it as seamless as possible, the UAB side is where it's almost more important in my opinion, because the pediatric side has been handled to the point that people with disabilities are living longer, and we're living through the pediatric age into adult care, and so now it's on the adult care to kind of pick up the slack where they've been previously not, um, meeting those needs, partly because they haven't had to.
Right.
Socially and medically, we have advanced over the last 30 or so years to where, okay, more of us are living longer and we're living in society longer. And so now that need for medical care at the adult level in the regular hospital is needed, or the regular primary care clinic is needed.
Mm-hmm.
And so we know statistically that people with disabilities who have that disability in childhood and then, let's say, live to adulthood have used adults medical care at a rate that is 9 times higher than the general population of adults. And so that care need is obviously there. And
Right.
so, and one study I read recently found that 90% of primary care physicians did not feel comfortable treating patients with disabilities. They did not have the
Wow.
training that necessary, whether that's socially or like medically, they were probably okay, but
Mm-hmm.
socially, they didn't feel comfortable taking care of those patients. Um, and so that's problematic. And then in
Right.
addition to that, we know that a lot of medical facilities aren't accessible. Um, I think I saw one study where like 83% of medical facilities don't have an accessible exam room. Well,
Yeah.
that makes a problem, um, when you go in for care, and if you can't access the exam table, then the exam gets thrown off. Like I read
Right.
it was one case study where a patient had gone in for I think it was an echocardiogram, and the however they traditionally do the test wasn't accessible, and so they did it in her chair. And when they did the echocardiogram in her chair, it threw off the results to where it was basically unusable. And so the
Oh, wow.
doctor, it just made the doctor's, plan of treatment got thrown off because like I can't,
Right.
the test to justify whatever my prescription is going to be or prescribed care, I can't justify it legally, whether that's insurance or whatever, because the test isn't viable. But it's not
Right.
viable because it's not accessible. And I also saw, adding to that, where like 30% of the basically the accessibility for mammograms and pap smears for disabled women are significantly, it's less likely to happen because of inaccessibility. The
Right.
machines used aren't accessible. And so,
Right.
yeah, it's,
I can attest to that one.
yeah, so like I said, there's several problems with that, and so STEP is helping in several ways. So one, obviously, we're the medical home for a lot of people, but then also
Mm-hmm.
we're doing a lot of educational efforts to where we can better prepare primary care physicians to
Mm-hmm.
meet the needs of patients with disabilities who meet them in their kind of their community setting as opposed to making them come to UAB or children's every time. And
Right.
so that goes back to, I mentioned to you Project Echo, and then that's kind of an educational endeavor to that end. So yeah,
Gotcha.
and then also we're doing our transition conference each year. So
Right. I think that's actually the next question I had was about the transition conference. Yeah. Okay, so the transition conference is in March, right?
yes, so it's
Of
March
yeah.
4th, March 4th of 2023. It's going to be at United Ability in Birmingham, Alabama, and it's going to be at their Link Point building. So we held it there last year, and it worked out so well. We decided to kind of do it again. Uh, so the intended audience for the transition conference is individuals with complex care needs or disabilities and their families, and we cover topics whether it's both social and medical, including the navigating employment, education, vocational rehab, SSI, Medicaid waivers is the big one that we cover each year, and we're going to
Mm-hmm.
cover more in depth this year because a lot of people have had questions about that. So if your listeners or people in the comments want to add anything to that agenda that they think is worth covering specifically, go ahead and mention it. We're building that out now as we, like I said, it's not until March, so we're kind of building the agenda as we speak. Um, so
Gotcha.
looking forward to
Cool.
it. It was really good last year, and so I think it'll only get better from there.
All right. Yeah. Um, okay, so let's go into other things you're working on to improve healthcare and like Project Echo.
Yeah, so Project Echo is a big one. So Project Echo is an acronym for Extension of Community Healthcare Outcomes. Um, so that's what that's an acronym for. It actually started at the University of New Mexico, and they realized how successful it was, and they kind of duplicated it elsewhere, including at UAB. And so Project Echo is a really cool program where it's designed to help patients receive the best care possible, regardless of the location. And so, if you think about New Mexico, it's really rural. There's a lot of
Right.
just open space in New Mexico, and that's kind of where it started. But we've taken that at UAB and done similar things. So, the idea is that primary care physicians across the state may not be as comfortable as UAB or Children's at treating patients with disabilities. But if we
Mm-hmm.
can educate those patients, or sorry, educate the physicians, then on disability, either specific disabilities like spina bifida or CP, or if we can educate on, care practices that may be problematic or have, best care um, processes that work better. If we can educate physicians on those things, then we can improve patient care throughout the state. And then we've made a dent in kind of the issue of, you know, physicians not being comfortable treating those patients. And if you treat, it also helps patients because the care is more readily available if they're able to go to their primary care physician that's in their town or their city as opposed to having to come, 3 or 4 hours to get to UAB. So
Right.
the way that, yeah, so it's a big deal. It'll make a big difference. So Project Echo, the way it works, it's a tele-mentoring approach. So they basically, experts at UAB run like a webinar, and it's attended by physicians who are interested in the topic, who then can learn from the experts. And then if there's like a case that one of them has, they can present it to the experts and say, hey, I had a patient with a disability come in, and I really wasn't sure what to do with them, as far as like social interactions, or, I didn't know what spina bifida was, all of those things, um, that tend to happen, that we know happen. And so if they can, present it to experts at UAB, then the experts in UAB can then kind of provide feedback and be like, hey, this is what you should do. Um, Whether that's a part of their presentation or they're just answering questions. And so that, I said, that allows for physicians to be better prepared for patients when they either roll or walk in the door. And so then
Right.
it's, I said, stuff like that. And then other than that, that's the big thing with Project Echo. So
Gotcha. That's pretty cool. Uh, no questions yet. Um, okay, so you might have touched on this a little bit. We've already talked about a lot. But in your emails to me, you've mentioned research that you're doing.
yeah, so I'm uh, kind of lucky. Interesting thing, I have a pretty decent connection with the online disabled community, um,
Mm-hmm.
through social media, and so I was talking to Betsy a while back about some stuff, and she had asked me to, as part of this Project Echo stuff, to do a presentation on uh, care practices that can be improved for disabled patients and patients with
Okay.
disabilities and complex care needs. And so I decided to reach out to social media and just be like, hey, what are some issues that I know of some, because I use a wheelchair and have CP and I'm hard of
Mm-hmm.
hearing, but I don't obviously know everybody's experience, and clearly there
Right.
are issues that are, widespread or that I'm just not aware of. And so I just reached out on Twitter and Facebook and said, hey, you know, what are some issues that have, you've seen as far as, transitioning to adult care, or just when you've been receiving care. Um, and I got a massive feedback. Like I got like
Oh,
120 responses.
wow.
And so Betsy then goes, yeah, that's a really great response. You're writing a qualitative paper. And I was like, okay, I'm an academic at heart. I've said before that I want to write a paper. And I do. I said I do. I'm very much an academic, and like writing and like researching. So I wasn't, that didn't phase me, but it was kind of a, okay, here's what we're doing. And so we're just kind of trying to have conversations with individuals with disabilities who are receiving care, where medical care is currently lacking, in the, what it's either providing, or how it's, you know, what issues that patients have run into that have kind of caused them to have issues. So I know at one point there was a comment that I received where it was like, I had a physician who just kind of kept calling me on the phone. Well, they were deaf. They're like, you're trying to schedule my appointment via phone call, and I can't communicate that way. And
Right.
so it's like, So that's an issue where it's like some of these issues that we found in the preliminary research that we've done, some of them are easy, they're fixable, and they're
Mm-hmm.
fixable in a way that doesn't add much issue for the physician. Like one of them I know was that a lot of people who either have migraines or have sensory issues, or even if they're autistic, they struggle with the lighting in hospitals and in primary care patient rooms. So the
Mm-hmm.
fluorescent lighting in the rooms, it's either too bright or it makes a buzzing noise that that negatively affects their experience. And
Right.
so I got like 20 people that mentioned that. And then somebody else, like the 21st person, goes, I finally had a doctor who dimmed the lights. And they when they turned down the lights, it changed my entire patient experience. Um,
Wow.
and so it's stuff like that, you know, physicians and medical providers, like, we can change some of that. Like that, some of that stuff is
Right.
relatively easy to account for. It's just a matter of being aware that that's a need and taking it into consideration. And so stuff like that. We've been really interested in kind of learning about that stuff, and so
Mm-hmm.
that hopefully we can kind of make things better. And so then it also allows us to provide examples and research that we can then present to providers, both that we're talking to, or if it gets published, fingers crossed, and I actually get it written. Um, but if it gets published, then it's out there for other providers to see, and then you kind
Right.
of you made a difference. So
Exactly. Yeah. That's
and so
pretty
we've
cool.
kind of, yeah, it's really cool. Uh,
You were saying something. Sorry.
no, I was just thinking through what I needed to say, and I kind of said it. So
Gotcha.
we
Okay.
kind of yeah, we got a grant to help with that, but I covered that through the Project Echo stuff. So we got a
Gotcha.
grant to help with all of those things. So
Gotcha. Okay. So this is actually one of my favorite questions because I like to know like people's stories and stuff. What led you to want to work with the disability community?
so obviously if it hasn't been clear, I have CP. I'm hard of hearing. I use a wheelchair. I've kind of been connected my entire life. Uh, didn't really have a choice in that card, in that hand. Um, and so for me, as you know, I grew up in Birmingham. I went to Lakeshore Foundation um, as a
Hmm.
kid and into teenage years. I played wheelchair basketball for Auburn University for 7 years and helped start that program. Professionally, it started. I had worked a couple of years with Auburn University's wheelchair basketball program as their academic advisor, and the it kind of that position had run its course due to other things outside of my control. And so at the time, it was the start of 2020, and I was like, I had been struggling to find a job elsewhere, and I had always kind of considered going back to school. And so when I did, I said, I'm going to go back into something that allows me to create a position or find myself in a position to help eliminate or alleviate some of the barriers that disabled people face in society, whether that's education, healthcare, general access. You're aware of a lot of it, I'm sure. Um,
Yeah.
and so I got into grad school at Troy and finish my MPA, which is a Master's of Public Administration. but alongside that, I did a graduate certificate in public health. And so public health kind of became my passion. It became what I was interested in. There's a lot of barriers for people with disabilities within healthcare, whether it's accessing
Mhm.
healthcare or, like, we know, for example, that like a quarter of patients with disabilities uh, don't either have a primary care physician, or they felt like their primary care needs were unmet, were not
Right.
adequately met on a year-to-year basis. And further, there's a lot of issues. I said again, 83% of facilities do not have an accessible exam table. And so there's a lot of those issues. As I was kind of finishing up my degree, I was like, okay, this is what I want to do. This is clearly an issue. And we also know from data and research how much access to healthcare directly impacts things like employment or things like
Mhm.
education. And it's kind of the it makes sense to you, I'm sure, but like if you have a healthcare need that goes unmet, take for example like pressure sores. If you get a
Right.
pressure sore and you don't meet that need, you can't really work the way you might want to work, or you can't really go to
Exactly.
school the way you
Yeah.
might want to go to school, because your medical needs are preventing that.
Right.
And so if we can make a dent in medical care and improve it and better meet those needs, then patients with disabilities are able to then, be employed more, um, advance their education if they want to do that.
Mhm.
And so it's kind of this whole interwoven situation where, you know, for example, 19%, only 19% of disabled people are employed. And so, but a lot of that goes back to the fact that, if they receive SSI, then, and thus Medicaid, they,
Mhm.
we have an asset cap with of $2,000 where you can't
Right.
work full time, or you can't work at all, because you
Right.
risk losing your access to health insurance and health care.
Right.
And so it's kind of this whole interwoven system where if we fix, whether it's through STEP or through, making differences in SSI to where Medicaid isn't directly tied to assets, or we boost the asset limits, uh, which is not really on my level. That's more congressional, but like I said, being that advocate, being aware of those issues and trying to kind of fix some portion of it, you make a difference elsewhere.
Right. Yeah. That's one of my biggest things right now is SSI, and
Mm-hmm.
I've always I can't have a full time job.
Right.
Um, and the I have a sociology degree, a bachelor's in sociology right now. I'm going back to school now for a certificate in medical coding and billing. Um, but I can't get a full time job in either of them because I'm on SSI and that cap is on
Yeah.
for,
And you gotta have it. So
yeah,
it's so.
and I can't survive without it
Mm,
on a part time job. Like,
right. Yeah, there's several disability advocates that I have connected with, and they all describe it the same way. And it's I can't refute it, can't disagree with it. I agree with it 100%. The current system is forced poverty. It is
mm-hmm,
forced poverty, and there's no way out of it. Once
Right.
there, I mean, there is, but it's really hard.
Right.
And our system, it is messed up. Yeah, to put it bluntly, it is a messed up system that needs to change. And I don't, that changes at the congressional level. It changes at the, you know, I know, for example, I read several studies where, and this as well, but in addition to the SSI system, like employers are a lot less willing to hire employees with disabilities. And so then
Mm-hmm.
they're a lot less willing to hire them. So, but then they're a lot less willing to give them full time jobs,
Right.
which would allow them to access health insurance through their employer. And so it's how do you get a full time job that gives you those benefits that allows you to, excuse me, allows you to leave or to get off SSI.
Mm-hmm.
Um, if if employers won't hire you and won't hire you full time. Uh, so yeah, it's definitely a. There was one just this is getting somewhat academic, but there was a study done
Okay.
in Kansas for years. Kansas had a high risk insurance pool for individuals with disabilities and other complex care needs, to
Mm-hmm.
where it was separate from Medicaid. And through that system, you got this high risk insurance, and it allowed people to continue working in their full-time job and not access SSI or SSDI. And it worked. And then eventually Kansas struck it down in like 2012, I think, because of cost issues. But it's like it worked. It did exactly what it was designed to do, and it allowed people to work um, in their chosen place of employment, without the risk of jeopardizing health insurance and health care as a result. And so these individuals they stayed employed longer. They had fewer healthcare needs that went unmet. Like it did everything it was supposed to do. And I said, but people don't want to fund those things, even though people with disabilities make up like 26, 27% of the U.S. population. It's very frustrating um, for any sort of progress to happen socially and economically. We need to make a change in that system. And it's like you, it's kind of one of the big things that I am, you know, tangentially trying to fight to change.
Mm-hmm.
But I said, it is not my decision. I can scream
Yeah.
at senators and state representatives all I want, but you know, they're the ones voting for it. So,
Yeah. Exactly. I just there was a thing to send a email to one of the senators about a bill that they're trying to pass
mm-hmm,
for upping the amount you can have in your account. And
mm-hmm.
I sent a email to one of our people in I live in Georgia now. But one of our people in Georgia, and we'll see where that goes.
Yeah, because that's the one that's gonna raise the. Is that the one that raises the asset cap to like 10,000?
It's something like that. Yeah.
Yeah, I think, which is still not enough.
Still not enough,
Realistically,
but it's
but
helpful.
it's better than 2,000. So
Exactly.
yeah, it's yeah, it's a total mess. Yeah.
Let's see. Okay, so what's one piece of advice you would give to someone that is transitioning from pediatric to adult care?
So I have a couple. So one is learning
Okay.
your health history uh, early on. So to understand what your disabilities are, understand what surgeries you've had, those kind of things. There are things that we get asked pretty much every appointment that you go to for primary care. But it's so needed, and so as you kind of take that transition, you know that's so important to understand, because that's kind of the basics, basic
Right.
information that your next provider will need. For me, one of the ones that I personally vouch for is kind of being as autonomous as you can be. Uh, I know not every patient can be completely autonomous in their medical decision making or their medical, you know, but putting patients in a position to be as autonomous as possible and starting that process as early as possible, it makes a
Mm-hmm.
big difference.
Right.
So
Let's see. What do you think is the hardest part about transitioning to adult care?
the hardest part is one that we discussed earlier. It's that loss of familiarity with the pediatric care.
Mm-hmm.
Uh, we know those providers, we know that world, whether it's Children's of Alabama or the pediatric world in Georgia or wherever you are. That pediatric, there's comfort in that, and so
Right.
transitioning to a whole new hospital, a whole new care team, that is definitely the biggest hurdle mentally,
Right.
uh, and even mentally, emotionally, somewhat physically, because you're trying to find those providers that are comfortable with you, you're comfortable with them, that they meet your
Mm-hmm.
needs, and they're willing to do it, and they do it well. I said, I'm comfortable. I know the people at Step will meet those needs if we need to, um, for any patient that comes through our door, that quality, as I explained before, that has that disability or complex care. But at the same time, like they're that isn't, there are things that we need outside of a step clinic, or whether it's
Right.
obstetrics or whatever it is, like that. That doesn't. As I tell everybody, we're not going anywhere. You know, we've lived through pediatrics. We're here now in the adult world, and there are more of us coming as medical and social advancements continue to allow us to live longer, and live into adulthood. I know there's a lot of advancements, like on with muscular dystrophy and spinal muscular atrophy, where
Mm-hmm.
patients who previously were dying at 18 or 20 or whatever are now living well into their 30s or into their 40s, or they're totally stopping the progression of SMA. So that just totally changes the equation as far as
Mm-hmm.
the patients that are going to be there for providers to treat. And so providers have to be prepared for that. And some of that, step is picking up some of the slack as far as educating primary care physicians so that they're better prepared for treating those patients. But a lot of that also falls to medical schools, need to educate and say, okay, you're going to be treating patients. Because what happened a lot historically is that med schools would say, okay, that's a condition, a disability of childhood. So whether that's
Mm-hmm.
CP or whatever, or spina bifida, it was a condition of childhood, and so it was taught that way, and so pediatrics covered it. But if you went into primary adult care, you may have gotten a brush of it when you did your rotation in clinicals with the pediatrics, but if you didn't, you weren't trained on it extensively. And so now that we're living longer and we're here now, primary care physicians and others have to kind of treat those patients, and they better be equipped to do it. And so
Right.
that's
Yeah.
yeah.
Yeah. It's funny that you had just like briefly mentioned Georgia healthcare. I'm actually still having to go to UAB for healthcare. I'm 3.5 hours away now.
Mhm.
Because there's nothing in Georgia for adult healthcare that like deals with a spina bifida.
Mhm. Yeah, because
Everything
in
is
UAB,
like pediatric.
because in UABs, because they have the spine bifida clinic at UAB or Children's in UAB, and so I I don't know where there's another one in the southeast. So I would imagine, yeah, it's yep, it's definitely problematic.
Yeah,
And
we I was having a shunt malfunction when I first moved here, and we were trying to find a place here, and there was nothing.
mm,
So that's
yeah,
also a big issue with like healthcare because there are people from all over that go to UAB just because there's nothing in their like
hmm
state.
yeah, I ran into that. I worked before coming to UAB. I worked at United Ability for as as an intern of sorts, um, but that was United Ability is the same way. They're the only one in the southeast that does what they do, and
Mm-hmm.
so they have to, meeting that need. Yeah, we'll meet that need, but you shouldn't have to drive 3.5 hours to have that need met, and
Exactly.
it negatively impacts care. I mean, I read as part of that um, study when there was a patient who, if they had not gotten care within like 4 hours, they would have died.
Mm-hmm.
But they couldn't get care where they were. So they had to
Right.
drive like an hour and a half to wherever they got care to do it. But it's like if you live several more hours away and you're not in a position, like what do
What do you
that's
do?
what do you do? Like
Yeah.
like that's not good. Um,
Yeah. Exactly.
and that's something where it's just like that to me is fixable. We can't fix every problem right away, but like that's providing that care and making getting physicians to provide that care that is fixable to me. Um, you know, so
Right.
that's kind of yeah.
All right. So my last question is there anything else you want to discuss healthcare
I don't
wise?
think
Anything?
I'm open to discussing a lot of things, but um, anything you or your commenters, did anybody comment and ask or input anything?
No, not yet.
Um, so I think I covered everything I needed to cover.
Okay.
So I said
Right.
I said Project Echo and the importance of STEP and all that stuff. So I think I
Yeah.
got everything. Uh, and like I said, we delved a little bit into uh, SSI and the problems with that. So I said we're trying to make a difference, trying to
Right.
trying to do our part to create some change. But I said it's definitely a process, but you know, every little step forward is is progress. So yeah.
Exactly. Right. Well, I think that was all my questions, and we have nothing on Facebook. So, thank you for letting me interview you. This was actually pretty informative.
So yeah, thanks for doing it. Hopefully I did well. I think I
You
did
did.
okay.
You did.
So I said if anybody has later on that watches it later, I said I will be kind of periodically checking the comments, um, and so I'll try to answer anything that comes up. And feel free to um, anybody who wants to comment with either ideas for the transition conference or um, care needs that have come up that they've you know want to input their part on my research. So that'll be fun.
Do
So
you have a way for them to contact you?
yeah, you can either email me at kcrain@uab.edu, or that's probably going to be the best way to contact me. Um,
Okay. All right. Sounds good. All right. Well, thank you for letting me do this. It was fun.
yep, thanks for doing it.
You're welcome. All right. I'll see you in my next broadcast, guys. Bye.